I'm Dr. Kevin Kavanagh from HealthWatch USA. I would like to talk to you about our commentary on preventable hospital-related mortality. Recently, there have been at least 3 studies which have estimated the number of avoidable patient deaths at hospitals to be over 200,000 each year. The findings of these studies have often been mitigated because they are based on what critics describe as flawed data. What is often not said was that the data tends to underestimate, not overestimate, the occurrence of these events. However, we feel the onus is on the facilities to provide better data and to demonstrate that the care they are providing is as safe as it can be. Even if statistical significance is not reached, one should still be concerned. If you were told you had an 80% chance of dying of cancer, would you be upset, or would you brush off the news because the p-value was not less than 0.05? If one only uses the 2 most rigorous data sets, the ones which use the global trigger tool and determine preventability, an estimation of over 167,000 preventable hospital deaths each year can be made. Granted, the subjects of these studies tend to be older and thus may have more adverse events, but factors such as diagnostic errors, onset after hospitalization, and the non-capturing of events were not included. Considering all of the factors, it is not unreasonable to estimate an annual hospital-related mortality of approximately 200,000 patients each year. In attempting to mitigate the importance of medical errors, some try to blame the patient. Medical errors need to be disassociated from the context of the patient. The patient's conditions or choices are not relevant when evaluating medical errors. For example, medical errors are not mitigated because the patient was going to die soon anyways, or because his life choices made the treatment necessary in the first place. Even if the patient was near death, this does not mitigate the occurrence of an event. For example, are passengers with a terminal illness who die in an airline crash not counted because they would have died anyways? Is the healthcare worker who potentially brings an early end to the life of a terminal patient guilty of any lesser of a crime than someone who ends a life during a robbery? The fact that the patient made poor life choices is also irrelevant. It is not the patient's fault that he became sick and had to go to the hospital. For example, does the National Transportation Safety Board mitigate the deaths that occur after a train crash because passengers did not choose to take an airplane, which is a proven safer mode of transportation? Again, the patient context is irrelevant. We need to remember that a preventable medical error which contributes to a death is not discounted by the status of the patient. Medicine does not have the moral authority to say that 1 day, 1 week, or a month of life is any more valuable than a decade of life. All life is precious. Determination of causality is also not a requirement. Causality is hard, if not impossible, to determine. Its determination has not been a requirement in other public health campaigns, and it does not mitigate the occurrence of a preventable, potentially fatal error. For example, did smoking cause a patient's death, or would he have died of cancer anyways? Did the patient die from his heart attack, or was it from his obesity, high blood pressure, diabetes, smoking, or the 2-hour wait in the ER? Which one was responsible? A preventable error which could have caused or did cause death should be treated the same. Similar to the National Transportation Safety Board investigation of airline crashes, all causative factors which either directly caused or contributed to the crash are investigated, counted, and dealt with. The complexities of proving causality is not used to mitigate the impact of an action taken to remediate a contributing factor. Preventable hospital-related mortality studies conducted in other countries are not applicable to the United States. Data derived from nationalized healthcare systems with central control cannot be extrapolated to the non-centralized U.S. healthcare system with a mixture of nonprofit, for-profit, and governmental healthcare systems. This graph is from the Canadian Institute of Health Information and shows the potential years of lives lost in various countries. Potential years of lives lost report deaths under the age of 70 and is used as a surrogate for healthcare system performance. As you can see, the United States performance is shown to be the worst, almost twice that of Sweden. Regardless of what you may think about this comparison, it does make the point that one should not use studies from other countries to predict the performance of the United States healthcare system. I am sometimes asked how many preventable medical errors and deaths are acceptable. I think the best answer of this, again, is with the airline industry. Would you ask how many preventable airline crashes are acceptable? We can and we must do better. Patient advocates are not calling to prevent problems which solutions are not known, but calling on facilities to implement known solutions to prevent all too common problems. What ties and binds the occurrence of preventable adverse events and mortality together is the willingness and determination of facilities to adopt a culture of safety and to invest in patient safety. Thank you.